The following program on PBS Fort Wayne is made possible in part by...
It's a new day at Parkview, another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected, we do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.
And good evening. Thank you so much for watching Healthline on PBS Fort Wayne. I'm your host tonight, Mark Evans. Tonight, since it is March, the month of March, of course, and Colorectal Cancer Awareness Month, we have invited for a return guest, our doctor tonight on the panel, Dr. Sunil Reddy. He is a colon and rectal surgeon. And doctor, so nice to have you here on the program this evening.
Thank you, Mark.
It's been about 3 years. I mean, long before COVID since the last time you were here.
Yes, time flies.
And I guess there's been some medical advances in your particular expertise. We'll talk about some of those. But diverticulitis and the treatment options we'll discuss. And the phone number is on your screen at 260 or 866-969-2720. Please call in your questions, whether it's for you or someone you love, and we'll get those answered for you. And then you can determine whether or not this individual needs to go see a physician. That's what this show is about, to help you. So, doctor, let's talk about something here. When I Googled today diverticulitis, by golly, diverticulosis came up too. So they sound the same kind of, but they're two different things. So why don't you explain those first?
Yes, yeah. So the diverticulosis, it means a condition where the large intestine develops outpouchings or pockets. Normally, the architecture of the colon, the large intestine, is smooth. But as we grow older, because of the dynamics of the stool moving through, sometimes people get these little pockets. We can pull up the slide one.
Oh, number one, okay.
Explain a little bit more about that.
All right, it'll take just a couple of seconds. What are we going to see when that comes up?
You can see.
Slide one. Yeah, there we go.
Yes.
That's it.
So as you can see, this depicts what happens in the colon as we get older. Normally, the colon pushes the stool through smoothly, but with time, if the stool is not enough for the colon to push, the pressure mechanisms work on the bowel, and wherever there is blood supply, those act as weak points, and the pressure leads to outpouchings, as you can see in the picture.
Okay, and these pouches have what inside of them?
So these pouches are like just the tiniest layer. The bowel is quite thick, in fact, but these pouches are very thin. They're made of like a little shell, so they're very susceptible to rupture. And now the presence of these pouches is called diverticulosis.
Okay.
And we see that in 80% of people.
80% of your patients?
Yes.
So most of us will have a form of this, but it doesn't become diverticulitis until when?
Until one of those pocket ruptures.
Oh, okay.
Yes.
All right.
And that happens in only 10% of people with diverticulosis.
All right. So hinging on that, how common is diverticulosis or diverticulitis?
Diverticulitis is in fact quite common. On an average in the nation, there are at least 2 million diagnoses of diverticulitis a year, of whom at least 150,000 need to be admitted to the hospital.
Oh, wow.
Overall, it's about $1.5 billion in cost to the healthcare.
Well, and you mentioned that most of us will have some form of diverticulosis at one time or another in our lives, especially the older we get. So when diverticulitis happens to happen, who is mostly likely to get that? What are the risk factors?
So the risk factors are actually, we're still trying to understand why this happens.
Oh.
So the understanding right now is that dietary factors, a little bit of ethnicity as well, genetics and lifestyle impacts the formation of the diverticuli and then subsequently the attacks. Mm-hmm. But overall, it's the older population, obese population, those who smoke, alcohol, and people who consume more red meat, less of whole grains, and more high-fat dairy. these are the risk factors for diverticulosis and subsequently diverticulitis.
Okay, well, we're going to talk more into prevention and treatment here in just a minute, but we have some calls coming in. Excuse me, it looks like line 5, we have Jill, who prefers to be off the air, and that's quite all right. So we'll just read her question for you. She is asking, how often does someone need a colonoscopy after the age of 70? And you know, colonoscopies come in handy for diverticulitis.
Yes,
right?
absolutely,
Okay.
yes. Good question. Colonoscopy, I can't overemphasize the need for screening colonoscopies, with March being Colon Cancer Awareness Month. This is a good thing to discuss. So colonoscopies we do recommend for patients after 50 years of age, and now the guidelines are actually saying 45 years of age to start doing the colonoscopies. Now, if anyone has no polyps and colon is normal at colonoscopies, we typically do not recommend doing the colonoscopy after 75 years of age, just for screening purposes. However, if there is any family history of colon cancer or prior colon polyps, then we recommend to continue doing the colonoscopies as long as they can undergo the prep and it is safe for them to get anesthesia.
Okay, so when you're doing a routine colonoscopy check, you're checking for diverticulitis.
The colonoscopy is done to check for colon polyps and colon cancers.
Okay.
But the diverticulosis is something we see in almost 80% of people getting routine colonoscopies.
As well as Crohn's disease, can you find that, see
Yes.
that as well?
Yes, we can see inflammation like Crohn's disease or ulcerative colitis or various other colon pathologies can be detected at colonoscopy.
All right, very good. And that phone number, of course, is on your screen. It's, I always say 260, but the long distance toll-free number, of course, is 866-969-2720. Feel free to call that. We're talking to Dr. Sunil Reddy, a colon and rectal surgeon. Let's go ahead and talk about the dangers of diverticulitis. Is it actually a life-threatening condition?
Fortunately, there is a spectrum of diverticulitis. Not all diverticulitis attacks are life-threatening. Majority of the attacks result in mild inflammation that leads to pain in the belly, maybe some nausea, vomiting, fevers. Majority of them do not have any pus pockets. It's just mild inflammation, which can be treated with antibiotics and bowel rest. But there is a minority of patients with diverticulitis who do get life-threatening condition where there is a real rupture of the colon. That results in a massive infection in the belly, and that can result in death.
Well, we can talk about the causes and the symptoms here in just a minute, but well, let's go ahead and slide into that topic. What does cause diverticulitis?
So as I discussed earlier, the change in the pressure dynamics result in these pockets rupturing. There has been some talk about popcorn or nuts and seeds triggering this. Although studies have not proven that, but anecdotally we do see patients reporting that they eat some popcorn or nuts and it happens. So we really don't know what actually triggers the attack, but when it happens, people do get quite a bit of abdominal pain, fever, they really don't feel well, and that's the time that they should seek a healthcare professional's help.
Well, what causes the fever in all this? Is it the infection?
It's the infection and the inflammation.
Oh.
Whenever there is an infection there, the human body tries to respond to that infection with inflammation, and that leads to fever and pain.
All right, and you mentioned a few of the symptoms before. I'd like to go over those a little bit more thoroughly, if you don't mind. Some red flags. What are the symptoms of diverticulitis?
So the diverticulitis typically happens on the left side of the colon. So any left-sided abdominal pain, loss of ability to eat, nausea, vomiting, fevers, these should alert the public and the patients to seek medical help.
Okay. Now, where are the appendix? Left side or right side?
The appendix will be right side.
Right side. So if you have pain on the left side, okay. So nausea, the vomiting, chills?
Yes. If the fever is really high, then yeah.
Of course, not in all cases, but in some, the rectal bleeding.
Now, rectal bleeding is a manifestation of diverticulosis.
Oh.
You need not have inflammation. Typically in the older population, the pocket will have a small blood vessel and that can rupture and result in torrential bleeding. So that's a totally different presentation where people come with massive bleeding from the rectal side.
Okay.
And that comes from the diverticulum,
All right.
even without a rupture or inflammation.
Oh, okay, so you can get that either way. How is this diagnosed?
So as I discussed, the symptoms like abdominal pain, fever, and when they come to the hospital, either as an ambulatory setting or to the ER, the main test that we do to figure out what's going on is a CT scan of the belly. because that will help us understand whether this pain is related to appendicitis or Crohn's disease, or is it diverticulitis. So that's the first test to do in addition to blood tests.
All right. What about a sigmoidoscopy?
Yes.
And would you explain what that is?
Sigmoidoscopy is basically colonoscopy.
Okay.
But we're just looking up to the sigmoid colon, which is the left colon. That's where the attacks happen. But we typically don't do the colonoscopy at that time of the attack because we don't want to make things worse. So we give antibiotics, cool things down, but we want to make sure what we're seeing is not colon cancer. Because colon cancer is a big imitator. It can present as inflammation, perforation, obstruction. So that's where the colonoscopy comes into play to make sure this is not colon cancer. So we do that after 6 weeks after the attack is cooled down. And the patients are fit enough to get the procedure.
And I noticed too, and we talk very candidly on this program, as you know, but I noticed that in some of the diagnoses, a stool sample is required. What are you looking for in that stool sample?
We test the stool sample to rule out infections that can lead to inflammation.
Okay, and blood too being passed, possibly?
Yes, I mean, the bleeding is one of the manifestations of any inflammation in the colon.
Mm-hmm.
Not that specific for diverticulitis, but we test the stool for mostly infections.
Okay. Now, as we've talked about the diagnosis and talking about some of the symptoms, how is diverticulitis treated? What would be your first step?
So it depends on how severe the attack is. If it is a mild inflammation limited to the colon without any perforation, we treat them with antibiotics, give bowel rest, nothing to eat any solid food, and within 48 hours things start getting better, the pain starts settling down, and then they can go home with some more antibiotics for a few days. Subsequently, we do colonoscopy and make sure it's not colon cancer. Now, if that attack is severe, where there is a perforation and a pus pocket next to the colon, that needs to be drained. So we talk to the radiologist and they'll put a small catheter and drain that pus out.
Okay.
In the worst case scenarios where there is a major rupture and there's stool or pus all over the belly, that calls for an emergency operation.
Okay.
Where we go in, cut out that 1 foot of colon on the left side and maybe do a temporary bag. And that's where people get a colostomy temporarily at least to cool things down.
And that is the traditional colon resection?
Colon resection,
All
yes.
right. And then you had mentioned in some of my correspondence with you via email the NICE procedure for treating diverticulitis.
Yes. Now, some people get diverticulitis which are mild or just have a small pus pocket, but they keep happening again and again. Now, that's the case where we recommend elective colon surgery to prevent it from happening again. So these days we do this with minimally invasive techniques with laparoscopy and the robot. And these techniques have allowed us to resect the colon and put it back together without the need for a colostomy or a bag with very small incisions so patients can recover fast and they can go home within a couple of days. The NICE technique, it's also called the NICE technique. It's the technique where incisions are absolutely small. The colon is also removed from the rectal side, so we don't even have to make even a bigger incision at all.
Do we have a slide on that?
Yes, we can pull up slide 3,
Okay.
which is a picture of a patient 2 weeks after the operation. So this is how it looks. Those little tiny incisions are what we use with the help of the robot and laparoscopy.
And what kind of surgery was done with this?
So this patient had recurrent attacks of diverticulitis. So to prevent it from getting worse, we removed about 1 foot of the colon and put the colon back together.
And you can do that with those small incisions, because
Correct.
I would imagine a huge incision, a foot long perhaps.
It used to be that way a couple decades back before laparoscopy came.
Uh-huh.
And now with the help of the robotic techniques, the colon itself is taken out from the rectal side. So the resulting incisions are just tiny keyholes. So this patient could go home the next day, and he was back to work 5 days after the surgery.
That's amazing, because I know years ago people have had these kinds of surgeries. It was a month or two before they can go
Correct.
back. You also have another slide I'd like to bring up, because I think it's very interesting. Whenever doctors bring slides, I like to look at them, and I'm sure the viewers like to look at them as well. But slide number 2, what are we looking at right there
Yes,
when we bring that up? There we are.
I wanted to show the viewers what these diverticuli actually look like when you do colonoscopy. So if you look at the curves, that's the normal muscular pattern of the colon. But the little gaps you're seeing, those which look like caves, those are actually the pockets, the diverticulosis.
Oh.
And that's what 80% of people have. And those are the pockets that can rupture and result in diverticulitis attacks.
Very interesting. Well, thank you for bringing those slides. Now, we already talked about when we need surgery and so forth. So we talked about the NICE procedure and the colon resection. So let's talk about prevention. Is there a magic pill you can take in order not to get diverticulitis or diverticulosis? I mean, so how do we prevent that?
So it's an interesting question because we're still understanding the pathophysiology of this problem, why it happens. In fact, if you look at historical notes, this never existed before the 18th century. This disease is a problem of industrialization and our refined diets.
Really? They
yes.
didn't have these problems, say, 150 years ago?
No, this wasn't even existent in human population. Even to this day, if you look at the third world countries where the industrialization is not as prominent and the diet is still traditional, diverticulitis is not a problem at all. It's mainly a problem of Europe and America.
And what does it boil down to? Nutrition?
Diet, yes. There is some element of genetic factors as well, but our predominant assumption is that it's the diet. So any diet that is high in red meat, more than 50 grams a day, anything that's high in refined grains and high-fat dairy, that triggers altered dynamics in the colon that results in these pockets forming. So the prevention aims at refining the diet and including more fiber, more fruit and vegetables, more whole grain. In addition, smoking and obesity do contribute to the overall colon health. So cutting down smoking and weight loss, physical exercise always helps.
All right. Well, if you're joining us, we are talking about colorectal situations and problems, and in specific diverticulitis. And we have Dr. Sunil Reddy, who is a colon rectal surgeon, and been very informative so far on tonight's program. If you have any questions for him, please give us a call on the number on your screen. It's your number on the screen at 866-969-2720. We have about 10 minutes left in the program. And we're moving on very nicely about this topic. If I've had a bout of diverticulitis, how likely am I going to have a repeat episode of it?
It's difficult to predict, but overall the likelihood of another attack is about 30% over the lifetime.
So once you've had it, there's a good chance that you might get it again. Okay.
Correct.
Well, that's good to know. Do you think diverticulitis can be cured?
Once these diverticuli form, once the diverticulosis happens, it cannot be cured.
Oh.
They are a part of the colon and they cannot be removed just like that. But the fortunate thing is not everyone with diverticulosis gets the attacks. And not everyone with the attacks needs the surgery. As I said, most of the attacks are mild and can be managed with antibiotics, bowel rest, and then subsequent lifestyle changes. So it's more of a prevention than cure. So the treatment protocol is aimed at trying to improvise the diet, try to prevent future attacks. And if the attacks do happen, we emphasize on timely diagnosis so it doesn't get missed and lead to major issues that may end up getting an emergency surgery. Because anytime there's an emergency colon operation, there's a high chance of getting a colostomy.
Yeah. I have a friend who just went through that. Can I still get diverticulitis if I've had an affected part of my colon removed?
Very good question. Since most of the diverticulitis attacks happen in that left side 1 foot, when we remove the 1 foot of that colon to treat the diverticulitis, the risk of subsequent attacks is much less. The rest of the colon, for some unknown reason, does not get the attacks, even though the diverticuli exist everywhere. So the risk is less than 10%. So the surgery is actually quite effective in preventing a serious recurrence.
Yeah, it just sounds like there are a lot of unanswered questions regarding diverticulosis and diverticulitis. Well, we have a question here coming on line 5. Carson decides he would rather not be on the air, but he is asking, what is the youngest age someone should get checked for diverticulosis or diverticulitis?
Since the diverticulosis is very prevalent in the population, there is no recommendation or guidelines to check for the diverticuli. Most likely, many people do have them and they're silent and do not cause problems. As I said, only 10% of people with the diverticular issue get the attacks.
Right.
So you don't have to worry about getting checked for that. But if you do get an attack, then that's something that you should keep a watch on, be in touch with your healthcare professional, and avoid a bad attack coming up.
And That's very good and wise information there. Here's something. I had a boss, one of my first jobs many, many years ago, I had a boss who once in a while could not work because he had diverticulitis, and it was because he had eaten, or he said that he had eaten some seedy foods like popcorn and some grains and things like that. But now we're saying that really isn't the case. And you mentioned that earlier in the conversation. It's something I did want to address because a lot of people don't eat those types of foods, high fiber foods, because they're afraid it might trigger the diverticulitis.
Correct. It has become a prevalent practice for people to avoid nuts, seeds, and popcorn. And there's been recent studies that showed that eating nuts and seeds and popcorn does not really increase the risk of attacks of diverticulitis. As such, it is safe to eat nuts and seeds. What we do recommend is to chew well, make sure it's balanced, and make sure there's enough carbs and fiber supplements along with it to make sure the digestive process goes without any issues.
Well, and now we're saying in the same conversation to eat that kind of food and also a lot of fibrous foods. What is the fiber doing? Is it cleansing, or what's it doing to the intestines when you eat that?
So the fiber does an essential job of absorbing water and keeping the stool bulk.
Okay.
Because for the colon to push the stool out, it needs the bulk in this colon, so that way it works well to push it out. In the absence of fiber, if you eat a diet that is rich in just meat or dairy, that results in the colon not having enough stuff in the colon to push it out. So the pressure mechanics change, and that results in the muscles in the colon getting too strong, and then the pressure results in these pockets forming up.
So in this case, the more the fiber, the better, perhaps?
Always, yes.
Okay, well, that makes sense. That actually makes sense. So how much fiber should I eat during a day?
So the recommendation is about 25 grams of fiber.
So what's that in?
It comes to as simple as a cup of cereal,
Okay.
with probably another cup of vegetables or fruit. And this has to be consistent.
Something every day.
Correct. The emphasis is that to start the high fiber diet from younger age. We do see a lot of people switch to a healthy diet once they hit the third or fourth decade, but by that time you already have this diverticular problem already there.
Mm-hmm.
So the dietary modification or the lifestyle change should start really young, almost when in school age.
Well, and for the fiber and for our viewers, just to educate them, we're talking about whole grain foods like breads, pasta, crackers, barley, brown rice, oatmeal, berries, and other fruits. What are some really good vegetables to have that are fibrous?
Beans, peas, anything with skins and peels, cucumbers. Most vegetables have a significant amount of fiber. And then substituting white bread with whole wheat bread, substituting pasta with whole wheat pasta, something which is unrefined cereal, that really helps.
Okay, well, if I can't get enough fiber from my diet, are there like fiber supplements that are good? You don't mention any brand names, but can you buy those off the shelf?
Absolutely.
Over the counter?
Fortunately, there are so many brands available, and they're very cheap, and they're all natural. They're made of seed husks, wheat bran, so it's not addicting to the colon, and it's really a very healthy thing to take every day. There are other benefits to using fiber, which is decreasing the cholesterol. It also keeps the overall colon health good.
All right, what about antibiotics and supplements? Anything that we should be taking on an everyday basis to help ward off any infection in our intestines?
Routine antibiotics are not recommended. In
Okay.
fact, they could be harmful.
Okay.
But probiotics is something that's probably most people are aware of.
Oh, my next question.
Yes, so essentially probiotics are the healthy bacteria which the bowel needs. And today we have supplements available which will kind of give you all the healthy bacteria you need in the form of capsules. Or even a cup of yogurt will provide all the probiotics you need. So there is some talk about probiotics preventing colon problems. We don't have strong evidence in the literature, but there is some studies that have shown that it does help in keeping the colon overall healthy.
All right, and a lot of things I've actually been able to put together and gather from this program tonight is that when you have these situations as far as your digestive system, when we're talking about intestines and your bowels and your rectum and so forth, the medical advances have advanced so much in the last couple of decades that I can see from doing my research that there really isn't any reason to fear having these things checked out? I mean, you talked about the minimally invasive surgery, also the minimally invasive tests that people can take. So why don't you speak about that since we have a couple of minutes left in the program?
Absolutely. Colorectal problems are prevalent in our population. So it's always wise to seek healthcare professionals' advice and assessment in a timely fashion. Number one, because colon cancer, 1 in 25 Americans get colon cancer in their lifetime. It's that prevalent. So the number one thing that we as colorectal surgeons or even primary care physicians, we want the patients to not get is colon cancer. And it's very easy to prevent. Colonoscopies are widely available. It's just the patients need to go and accept and get it done. And that will detect a lot of colon problems which we can treat in a timely fashion.
And what are the things that you need to ask your physician? Because the physician is definitely going to be referring you to another physician of that specialty. So what kind of conversation do you need to have when you go in and say, I've got some concerns? Honesty is the best policy, but what are some of the main things that they need to know?
The main things they need to know are that these procedures are safe. For example, colonoscopy, it does have some risks like any other medical procedure.
That's a piece of cake.
Right, but it's absolutely safe. The risk of complications happening is 1 in 1,000 or 1 in 10,000. And even those, if you detect them, we can treat them. So there's no need to be concerned about problems happening during these tests.
And the almighty colonoscopy, I mean, they find so many things. They can actually take some of those polyps out if you happen to have polyps. So they can take those out during that procedure, can't they?
Absolutely. 90% of polyps are very small, and we can take them out right then.
Very good.
Yes.
Well, Dr. Reddy, thank you so much for being here. Always informative, and we'll have to have you back again. But I'm glad we had you here for March Colorectal Cancer Awareness Month.
Thank you very much, Mark.
You're very, very welcome. And we thank you for watching, and we'll be back next week for more on Healthline here on PBS Fort Wayne. Until then, good night and good health.
The preceding program on PBS Fort Wayne was made possible in part by
It's a new day at Parkview, another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected. We do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.